Welcome back, ladies and gentlemen. It's an absolute honor and privilege for me to welcome Professor Dr. Rohan Sequeira, consultant cardio-metabolic physician, specialist in non-invasive cardiology, diabetes, endocrinology, and obesity management, honorary consultant physician to the Governor of Maharashtra, senior consultant physician at Jaslok Hospital, St. Elizabeth Hospital, S.L.Raheja Hospital, and Holy Family Hospital. He's a leading practitioner from India and across the globe, and Professor Dr. Rohan Sequeira will provide an in-depth update on the latest R&D and evidence for harm reduction. I must mention here that Professor Dr. Rohan Sequeira is unwell and running a very high temperature, but despite that, he has made it to this conclave. So thank you in advance, Professor Dr. Rohan Sequeira. Without further ado, I hand over the floor to you.
Thank you, Mr. Ivan, for that wonderful introduction. And yes, even though I'm still unwell, life goes on. And like harm reduction, we have to reduce harm in our personal lives as well. So I'll just make a brief presentation on what have been my perceptions of harm reduction, how I've been working with a few patients with regards to harm reduction, and how science and industry needs to innovate and change people's behavioral patterns and give them that benefit of harm reduction. So I'm going to speak about what exactly is harm reduction. It's actually a strategy. It's not what you would say. Harm reduction is it's not some kind of a concept which is there existing out there, but it's a strategy. It's defined. There is a very, very clear-cut guidelines and principles for harm reduction, and it's directed towards individuals or groups. The objective of this strategy is to reduce harms associated with certain behaviors. Now, there are different kinds of behaviors that we have, different kinds of addictions that we have, and how do you reduce the harm for that? To get a brief understanding of the areas in our society today which actually need a very strong addressal with regards to harm reduction, and which has a socio-politico-economic impact. Number one in the world today is alcohol. Number two is smoking. Surprisingly, but not unforgotten, is high sugar. I mean, you have so many people who are addicted to sugars and high sugar products. Then you have drugs, and you have tobacco products, which are non-smokable tobacco products, like you have the pan, you have the gutka, you have the different kinds of chewable tobacco. So these are the areas which actually need a lot of harm reduction. The problem with any of these addictions is because of the dopamine system in the brain. People are addicted to these certain kinds of things, and because of the certain patterns of their lifestyle and behavior, it's very difficult to get out of these. So if we cannot stop them, can we reduce the harm? And that's the entire objective of the harm reduction arena. Now, if you look at any person who has been associated with a kind of addiction pattern, or if you have been associated with some kind of a substance abuse, or some kind of a harmful kind of a behavior or a pattern, you see the first thing that starts, this is something which is called as the continuum of use. The first step is an experimental use. Then you have a social and ritual use. Then you have a situational use. Then a binge use. Then we call it an abuse. Finally, a dependence. And then finally, we come to a very, very addictive situation where it's called severely and persistently chemically dependent. This is the continuum of use for any kind of a addictive behavior. And how do we break that behavior is what is important. What are the different levels of harm reduction that we see in society today? You see an individual level of harm reduction, which can be given to a person on a one-to-one counseling. You have a community level of harm reduction, which is given by a community. Maybe you have an agency, or you have a support group, or you have different kinds of levels of harm reduction. And then you have an institutional harm reduction, where a person is admitted in the hospital and they undergo the protocol. If you look at a community-based type of a harm reduction, I would call Alcoholics Anonymous or different support groups which help. And an institutional is where a person is completely addicted and they need to be rehabilitated. For example, you have drug addiction, you have alcohol addiction, you have different kinds of addiction which require an institutional harm reduction. So when you look at scientific evidence in every area of harm which is there, that we are exposed to, Research is happening every day, and we know that there are a lot of behavioral scientists, there are a lot of chemical scientists who are working with how dopamine can affect you and how you will get addicted to something. There are many drugs which help you to get out of harm reduction. You have drugs like bupropion, you have different kinds of naltrexone kind of substitutes which can help you reduce your harm. But at the same time, scientific evidence has to be combined with a behavioral strategy, because just science by itself cannot reduce harm. It has to be combined with a behavioral pattern, and this is where a lot of work needs to be done. Now, there's a lot of, when you look at cigarette smoking, for example, we all know that tobacco has been there for thousands of years, but now evidence-based data is clearly coming out with nicotine delivery systems like electronic cigarettes. You have the electronic nicotine delivery systems called ENDS, and different kinds of tobacco delivery systems like you have HEATS, you have IQOS, you have different kinds of products which are coming out, which clearly do not cause as much harm as a regular normal cigarette. And in fact, there is some data which has been published in the UK. The NHS in the UK has got a lot of data as to how an ENDS kind of a formulation can have an 80 to 90% harm reduced effect with comparison to smoked tobacco. If you, for example, if I ask my patients to quit smoking, and if I switch them over to a chewing gum or if I switch them over to a nicotine patch, the probability of that patient reducing or stopping smoking is only 7%. Because along with the nicotine addiction that the patient has, it's also the entire smoke, the look and feel, the taste in your mouth. So it's not only just a chemical imbalance or a chemical addiction. It's also a behavioral addiction that the patients need to undergo therapy to remove them out from. Now, as you know, in many countries all over the world now, they have been banning certain newer harm delivery alternatives, like electronic cigarettes have been banned in India, Thailand, many of the other countries. Unfortunately, it's not been banned in the US, in Europe, it's not banned in the Middle East. For reasons which we may not want to address today, but banning newer harm-reduced alternatives is not the answer. The answer is to have a proper scientific evidence whether these techniques can reduce harm over a long period of time. Now, when scientific evidence is combined with a behavioral issue, it becomes a very, very potent tool to address harm reduction. If you see the DRAM article, which was published in 2018, it says, don't practice what you preach. So abstinence versus harm reduction has got a very big potential. If you compare a patient who is who's abstaining from a particular harmful product, and you reduce the harm, the chances that the patient would go for the reduced harm is much more likely than the abstinence, because then these patients usually relapse. And when they relapse with a much greater effect. So this was a study which was done in UK, where they showed that, when you compare abstinence with harm reduction among drinking, among alcohol with college-bound students, what they found was that those who had a harm-reduced alternative, by giving them behavioral pattern therapy, by giving them a reduced harm substance or reducing the quantity and strength of alcohol, these young college students had much greater potential to reduce their harm compared with those who were abstaining. Also, a very dear friend of mine, Dr. Riccardo Polosa from Italy. He's a very dear friend of mine. We are together on the Italian Medical Council. So he had a very interesting publication where they took a fresh look at tobacco harm reduction and how an electronic cigarette or other tobacco products like snus can actually reduce harm and medical related complications over a long period of time. Now, this is something which is really, really important, and we need to address this with a very, very immediate effect. Now, science-based harm reduction is a very, very good way to go. I would suggest that evidence-based harm reduction is one of the only ways in which we can actually attain long-term compliance and adaptation at all three levels. You can have it at an individual level, you can have it at a community level, and you have it at an institutional level. So science and behavioral patterns are integrated into each other to form a good harm-reduced alternative. Now, reasons for failure why people want to, give up and go back to their old addictions is, one is limited availability for the harm-reduced alternatives. That is not a very major reason. It's just a minor reason, but yes, it does play a role in failure. The most important reason for failure is the person himself is not motivated enough and he's not ready to quit. And this is one of the main reasons where behavioral patterns come into play, where people understand what's going on. So it has to be a multifactorial approach. And of course, peer pressure. If you have 10 people telling you that this is not what you should do, and that kind of plays in your background psychology, and that also helps a lot. Lack of peer pressure, a positive peer pressure, not go to the club or the pub and someone says have a drink, have a smoke, but rather you surround yourself with people who actually encourage you to give up, has a very, very positive impact. So that lack of peer pressure or lack of positive peer pressure also is one of the main reasons for failure. If you look at the e-cigarettes, I'm just giving this as an example because there's a lot of published data. Patients or people who were smoking regular tobacco cigarettes, when they switched over to an electronic cigarette, had a much longer period of harm reduction than those who gave up completely cigarettes. So this is data. I'm not going to go into the statistics, but the data suggests that it's got a very high uptake rate. It's supported by many of the governments, especially in UK, in the Middle East, and the US. But that's a lot of debate going on there, so I'm not going to go there right now. Now, when you look at the behavioral aspect and what behavior plays a major role in harm reduction, this is called the trans-theoretical model of behavioral change. So usually we are most of the non-addicted people are at a pre-contemplation stage. I'm not considering it. And then they move to the contemplation stage. They start thinking about it. And then they move to the preparation stage. I'm planning to do it. And then you have the action phase where they say, I'm actually doing it. Now, from there, how do we transfer into the pre-contemplation stage? Then you say maintenance of staying with it. This is where harm reduction works. Harm reduction works in the maintenance or the return relapse phase. It doesn't work in this pre-contemplation to the action phase, but it belongs to the maintenance phase. You're staying with it, but you're doing it with a less harmful method. And that's what the entire concept of harm reduction is. You continue doing the same thing, but with a less harmful side effect or an outcome. Now, of course, the ultimate goal would be to not doing it or stop doing it. So the objective of every harm-reduced alternative is to stop doing it, not staying with it. So that is the objective. I have a lot of patients who used to smoke cigarettes. I shifted them onto electronic cigarettes, and I'm very happy to say that at least 80% of my patients started reducing the amount of nicotine over a period of time. And I've got a lot of patients now who have completely quit cigarettes and nicotine-based electronic delivery products. So there is a very strong potential. Now, if these same patients were put onto a nicotine patch, or if they were put onto a nicotine chewing gum, which are also harm-reduced alternatives, the probability that they would smoke again is very high compared when you shift them to a lesser harm reduced alternative like electronic cigarettes. So everyone hurts themselves. This is basic human tendency. We always have the psychological need to do things we don't need to do, and many of the reasons why we do. And that's not what we are here to debate about, but what we as a scientific and a psychological community would like to look is that at least if I cannot stop you from hurting yourself, at least I can reduce the harm. So the 4 pillars of harm reduction and science and behavioral patterns is number 1, maintaining health and dignity. You have to maintain both, but with positive outcomes. Second is maintain participant autonomy. Now, not everybody who undergoes harm reduction wants the world to know about it. And there has to be included into the principles of harm reduction autonomy, where patients' autonomy or people's autonomy is maintained. Then you have a participant-centered services. If the person is not motivated, there's no point of doing this entire thing because the person will again slide back into the continue doing it more and he's not going to do it. And at the end of the day, we have to be real. We have to have pragmatism. We have to have realism. We know that, we believe in the Murphy's Law. If something has to go wrong, it will. So there's a very, very high chance of people who are in that pattern or in that addiction kind of a mode that if they're not supported by society, if they're not supported by their loved ones, they're going to slide back into that particular pattern of harm, of harming themselves. And, before I end this short talk, I would like to quote Dalai Lama, who had given a wonderful statement. I believe compassion to be one of the few things we can practice that will bring immediate and long-term happiness to our lives. I'm not talking about the short-term gratification of pleasures like tobacco, alcohol, sex, drugs, or gambling, but something that will bring true and lasting happiness, the kind that sticks. So keeping the words of the Dalai Lama in mind, I want to thank you for this short presentation. Of course, the time has been short and, I can't take an excuse for saying that I'm not well, but, it was a pleasure to address this, sir.